Everyone. My name is Melinda Southard. I'm a Deputy Administrator here at the Nevada Division of Healthcare Financing and Policy, and we'd like to welcome you all to our Stakeholder Update Workshop today. Really excited to share some important updates with you and looking forward to the discussion. So we'll go ahead and get started with our presenters today. First, I'd like to hand it over to our Administrator, Stacy Weeks.
Good afternoon. Thanks, Melinda. I'm glad to see everyone here. Next slide, please. We'll go ahead and just dive in. We've got a lot to cover today. So the purpose of the meeting is to give you all an update on implementation of major projects. Some of them were from 2 sessions ago, and then some are from last session. And we also want to give you a heads up and kind of get some feedback from you all and to help us with our budget planning for the next legislative budget cycle, which is in 2025. And we are already, as you probably already know, working hard to plan for the next budget cycle. And then at the end, we'll open it up, like I mentioned, for public feedback on that. And then also to gather, any other feedback you may have or questions on implementation. Next slide, please. All right, so as you can see, we have a pretty packed agenda. As usual, we're going to go through the division overview for those of you who may be newer to our work here at the Division of Healthcare Financing and Policy, and then we'll walk through some of our major projects. As you can see here, the list is growing. And also, like I mentioned, bill implementation updates, and then the budget planning, and again, open up for comment. Next slide. Our mission is to really look at promoting a healthier Nevada. I think you all are familiar with our vision and our mission. And a lot of that has to do with really making sure that our recipients get access to healthcare and that we are promoting access in a way that is affordable for our taxpayers in the state of Nevada. Next slide, please. This is our leadership team at this time. As you can see, we have all positions filled, so we're very excited about that. We have everyone, I think, today on the call with us. We have Jennifer Krupp is our new deputy over finance. She is on. Also, Cynthia Leach was recently promoted to our division compliance officer. It's a new role at the division that was funded last session, and we're very excited to have this position. And then also we added Dr. Duncan, who is our new pharmacy director. She comes to us from California, and very excited to have her on our team. Next slide, please. All right, so just a quick recap of everything that happened. If you forgot from last session, we had 52 bills that were passed and signed that impacted our division. 2 required new state regulations or will result in that. We have 24 other major projects going on, though, in addition to the 52 bills that we're looking at, and 39 system updates and 22 new state plan amendments that we are working on, and 21 policy updates that are related to those new bills. So overall, just a quick heads up, we are over halfway through with the bill implementation. I will say our team is really doing an amazing job. It's been a heavy lift. We had a lot to do. It was good stuff that we were implementing, but our team has really done a great job in a limited amount of time with a lot on their plates. Right now, 4 bills are implemented fully at 100%. 6 bills are very close to being done, as you can see, and typically those are the ones that are sitting with CMS, and we're just waiting, or there's some system changes that we need to have in place to make sure that we can operate the way we need to implement the bill. And then 15 bills are about halfway complete, and 20 bills are kind of under halfway. And some of those bills really are just getting started because we are waiting on vendors that we need to do the work and working with purchasing on getting those contracts, or the deadline for implementation is actually next year or later this year. So just want to note that some of these are done now because of the deadlines in state law for an effective date. At this time, as you can see, we estimated we would need to do 22 new state plan amendments. Our team has submitted 20 state plan amendments to CMS at today as of January. So we're very, very excited. We've done, like I said, a lot of work and lightning speed on our end. And then also we've done 10 policy updates related to this work or that have gone to public hearing. Next slide, please. Okay, major project updates. I'm going to kick it over to Cynthia Leach, our compliance officer, to let her give this update. Thank you.
Hi, good afternoon. My name is Cynthia Leach, and I wanted to share just a quick update regarding the centralized credentialing project. We are on track to implement centralized credentialing process for enrolled providers by January 2025. The new process will be available for all Medicaid enrolled providers, including those who bill for services through managed care plans. The goal is to streamline and simplify the credentialing process for providers. The procurement process is currently being finalized for a centralized credentialing vendor. We are nearing the end of the negotiation process, and the contract is anticipated to begin March 2024. Once the vendor is onboarded, we will be developing a project plan for communications and collaboration, particularly with our contracted NCEs. In the meantime, we have a link to the PowerPoint presentation that was shared at our initial public workshop that gives the overall intent and goals of the project. This information can be found at the link shown here. And I'd be happy to take any questions at the end of the presentation about the project. Thank you.
Good afternoon. I'm Sandy Rublet. I'm a deputy with the Division of Healthcare Financing and Policy. I'm here to give an update on the public health emergency unwind. The team has been working really hard in conjunction with our partners at the Division of Welfare and Supportive Services. In 2023, we began the unwind, meaning we started doing redeterminations for recipients after a 3-year pause. Last quarter, we did have to pause the redetermination activity because of a policy clarification at the federal level. So we did stop doing procedural terminations and did reinstate about 114,000 members. We were able to restart our redeterminations effective January 1st of this year. So renewal packets for coverage on January 1st, 2024 were mailed in November. Individuals who did not return their packet by this date were disenrolled. Our unwind is expected to end in September, and recipients are reminded to check their mail and complete the renewal packets as soon as possible to ensure that they don't lose coverage. We have some resources here at the bottom of the deck, but I did want to share some statistics from our January renewal run. So prior to the PHE, we did have about an 11% ex parte renewal rate, meaning that the member did not have to do anything, and a caseworker also did not have to do anything to renew coverage. As of January, our ex parte rate has gone for the FMC population to nearly 80%. So meaning 80% of those due to renew that month were renewed without having to return paperwork and without a caseworker having to do any intervention. Additionally, about 47% of the MABID population, that's the age blind and disabled, were also renewed during that process. And then the disenrollment statistics for January 1, we did disenroll for procedural reasons 4,802 members. Previously, our disenrollment rate was an average of about 40,000. So that is a huge improvement. And of the 4,802 that were disenrolled, 1,485 were under the age of 19. So we're keeping a really close eye on that. I will put a link in the chat to our dashboards that we use for monitoring that are public. Anyone's welcome to look at those at any time, and it shows, detailed information, including geographic areas of where these folks are that are being disenrolled. So, and I will also answer any questions at the end of the presentation. Thank you.
Hi, good afternoon, everyone. My name is April Karn, and I'm Chief of Information Services here with the division. Wanted to give just a quick update on our All Payers Claims Database project. The division will be working closely with OnPoint Health, who is the vendor that was awarded the contract to assist us in moving forward with this implementation. Going forward, we'll have a project kickoff scheduled, and then we'll be pursuing the creation of the data submission guide, which will be our #1 priority. Stakeholders will be given the opportunity to provide feedback on that document prior to final publication. Regulations with regards to the APCD are being finalized now, and we will be hosting another workshop so that stakeholders are granted the opportunity to provide feedback prior to the regulations being submitted to Legislative Council Bureau for review and approval. We do have our webpage available, and I've got it noted here on the slide. The intention is to make sure our stakeholders have access to the latest information and details around this project. So I encourage you all to go click out there and see what we've got posted. And then happy to take any questions at the end of the presentation.
Good afternoon, everyone. My name is Sarah Dearborn. I am the Behavioral Health Benefits Coverage Unit Chief with Nevada Medicaid, and I will provide a quick overview of our newest 1115 demonstration waiver for substance use treatment in a residential setting. So Nevada received formal waiver application approval December of 2022 and formal implementation plan approval in May of 2023 to be able to use federal Medicaid dollars to pay for substance use disorder treatment in a residential setting, also known as an institution for mental disease, no longer excluding the ages between 22 and 64 years old. So very exciting news there. As of August 2023, our Medicaid Management Information System was updated so eligible providers could begin billing for substance use disorder services in these residential facilities. The division is working to improve residential payment rate and methodology, and will be pending federal approval of a state plan amendment coming soon. Currently, providers can bill for these services individually or receive SAPTA grant funds if awarded to cover costs. So be on the lookout for a public workshop opportunity specific to this in February or March. Lastly, later in 2024, we'll be seeking federal approval to also cover treatment for serious mental illness in these same institutions for mental diseases or residential settings. Next slide, please. So for this next slide, I wanted to provide a snapshot of the work the Behavioral Health Benefits Coverage Unit will be working towards through March of this year. Most of these changes will increase access to Medicaid-eligible Nevadans in need of behavioral health care. And many of these projects are already in motion and have been in process for a while. So you may have already heard of some of these initiatives. However, we will also be sprinkling in some new projects to include many of the bills that were passed during session that supported Nevadans' access to behavioral health services. All projects will include significant research as well as engagement from the public and stakeholders as we move these accomplishments forward. So you'll see opportunity for public engagement through workshops as well as listening sessions to learn and provide feedback. If you turn your attention to the top of the slide and the light blue cloud-shaped icons, these are opportunities for public engagement and discussion through the public workshop or listening session process. You'll see we hosted a listening session on how to become a certified community behavioral health center back in November. Upcoming on January 23rd, so right around the corner, we will be hosting a public workshop related to changes from Senate Bill 191 for applied behavior analysis services, which I'll talk a bit more specifically later on in the presentation. Then targeting a mid-February, early March timeframe, we will host a public workshop for proposed bundled daily rates for the residential substance use treatment providers that we hope to submit to CMS for approval during the April 30th public hearing, as previously noted on the previous slide. Near the middle of the slide, you'll see two gray arrows. These are two new provider types in development to support both the work being done to build out Nevada's crisis system, as well as the evolution of substance use treatment services to complement the 1115 substance use disorder treatment demonstration waiver. Near the bottom of the slide, you'll see several purple boxes full of projects we have and are moving forward. First, you'll see in November where the focus was on public engagement for updates to the federally qualified health center policy, specifically related to behavioral health services, as well as how interested providers can become certified as a certified community behavioral health center as well as our public hearing held on November 28th, where policy changes were made to comply with Senate Bill 119 and Assembly Bill 156, also talked about later in the presentation. Next, beginning January 1st, 2024, Nevada no longer will limit how many certified community behavioral health centers can be enrolled statewide under provider type 17 specialty 188, opening access to enroll in this innovative behavioral health treatment model. Moving forward to our January 30th public hearing, we will be presenting proposed edits to Medicaid Service Manual Chapter 2900 for our federally qualified health centers to again clarify behavioral health service delivery in an FQHC, and Medicaid Service Manual Chapter 400, Mental Health and Alcohol and Substance Use Services, to propose extended time and distance standards to align with best practice, as well as clarify the requirement for a peer to be certified if part of a designated mobile crisis team. Next, planned for the March 26th public hearing, we will be proposing changes to align with the requirements of Senate Bill 191 for applied behavior analysis services, as previously mentioned. At the very bottom within the blue arrow, I've listed the 2 state plan amendments that are currently on pause, or as CMS notes, requests for additional information, or RAI. We're working informally off the clock with CMS on wrapping these 2 state plan amendments up. The first is related to crisis services, or specifically rate and coverage methodology for intensive crisis stabilization services. This same state plan amendment also incorporates coverage definitions for our newest mobile crisis delivery by a designated mobile crisis team that complies with CMS's Section 1947 requirements. We are working on getting the newest edited state plan language posted for an additional 30-day public comment period, so please be on the lookout on our public notice website for that getting posted soon. The next state plan amendment is for Certified Community Behavioral Health Center reimbursement methodology. CMS has requested that we repost our edits with our most recent additions of how often providers are able to rebase their rates. Providers will be required to rebase one time every 5 years, but there will no longer be an option for providers to request rebases more frequently, even if they cover 50% of the actuarial costs. I understand this slide addresses many different subjects and may take some time to soak in, and I'm happy to answer specific questions at the end, or our behavioral health benefit coverage unit is available through email. For now, I'll pass it over to Stacy.
Thank you, Sarah. Stacey Weeks, Administrator, Department of Justice update. So we are still the same update we gave last time, but we are getting closer, I think, to finalizing an agreement, so I do think next time we meet with you all, you guys will have a better update. But as you may recall, in October of 2022, the U.S. Department of Justice found that Nevada does not provide children with behavioral health disorders with adequate community-based services. Instead, we rely mostly on segregated institutional settings like hospitals, residential treatment facilities to serve kids with behavioral health needs. This essentially violates the Federal Americans with Disabilities Act, and they put out this finding. And so now we are in the middle of confidential negotiations with them on a settle agreement to avoid litigation. At this time, like I mentioned, we are still finalizing that agreement, but and once it is finalized, we will be hosting a public workshop and a meeting to walk through it and really talk through some of our plans for implementing the changes and also getting stakeholder feedback. Sorry, as we do that. Thank you. Next slide. All right, I'm going to turn it over to Dr. Benson.
Good afternoon. My name is Dr. Keith Benson. I'm the State Dental Officer here at DHCFP. And I wanted to review dental coverage for adults with diabetes in 1115 waiver. The application is still pending federal approval, and we are looking to amend the application to transition to an implementation date to April 1st, 2024 due to this delay. We were also able to add 8 tribal health centers to this waiver in order to provide dental services to those with diabetes. The new dental services will mirror those available for pregnant women, and coverage only applies to care provided in those participating FQHCs and tribal health centers within the waiver. Thank you.
Thanks, Dr. Benson. I think we'll pass it back over to Stacy to go over the private hospital provider tax and payments.
Thank you. Sorry, I hope my computer's not glitchy. I keep getting glitches on my end, so I apologize. So we have some good news on the private hospital provider tax program and the new supplemental payments. We kicked off the new program earlier this year, just started it this year, 2024. We did receive federal approval for all the supplemental payment programs, including the state directed payment. Record timing from CMS on that last one, so that was good news. We did get payments from all hospitals, so very much appreciate every hospital that worked hard to get the invoice paid and their first tax paid, and we got the first payments back to the hospitals in supplemental payments last week. So everything's moving along. We're looking at implementing the state directed payment in March. For state fiscal year 2024, the division is applying a ramp-up period to avoid cash flow issues. So we're doing 4 assessment and payment cycles in this last 2 quarters of this fiscal year. But starting state fiscal year 2025, we're going to have invoices and those payments occurring on a more regular quarterly basis. And as you can see here, for state fiscal year 2024, the total in new supplemental payments that will go out to the hospital, state and federal share is $552.6 million. The reason it's so much lower than the projections for 2025, which as you can see are 926 or actually 27 million on average, is because the state's fiscal year 2024 really did not include a full year of state directed payments. So once we have a full 12 months of state directed payments in state fiscal year 2025, you will see that the amount of money that is paid to the Nevada private hospitals is a lot bigger, and it will continue to grow that direction. Next slide, please. All right, Jamie, I think this one's yours.
It sure is. Hi, everyone. My name is Jamie Evans. I'm Acting Chief of Managed Care and Quality Assurance here at DHCFP. The division is on track with the implementation of statewide managed care by January 1st, 2026. During our stakeholder meeting in September, I mentioned that this expansion effort coincides with the beginning of the new managed care contracts. DHCFP did receive Board of Examiner or BOE approval on January 9th to begin working with Manat Health Strategies on the RFP and contract development process. Thus far, DHCFP has received 31 detailed responses from the RFI that was posted last fall. Manat will assist us with summarizing the feedback along with the feedback that we received from the rural hospital tours that we did in the fall of last year as well. Public workshops will be held during the first half of this year where we will share what we've learned to date and ask for additional feedback. We want to ensure that our understanding of the feedback we've received and give the opportunity for others to chime in as well. The first public workshop is scheduled for February 22nd, 2024. The statewide managed care website will continue to be updated as we move through this process, and you can access that page via the link on this slide. Thank you, and I think I'm handing it over to Casey.
I almost forgot to unmute myself. Good afternoon, everyone. My name is Casey Ingris. I'm the Chief of Compliance for DHCFP. And next we'll be walking through some updates on implementation activities for our bills from the 82nd legislative session. And so first, we kind of wanted to go over some Medicaid terminology that we'll use, and you'll see these terms in the next several slides. One you've probably heard a lot already is SPA, or State Plan Amendment. And the state plan is our contract with the Center for Medicare and Medicaid Services, or CMS, that describes how the state administers its Medicaid and checkup programs. And so anytime a change needs to be made to the state plan, such as legislation being passed, we're required to seek CMS approval of those changes by submitting a state plan amendment. Next, we have MSM, or Medicaid Services Manual. And this is what sets forth the policies for administering the Medicaid and checkup programs in accordance with the state plan. and the division adopts changes and new provisions to this manual at public hearing in accordance with statute. The next term we have is MMIS, or Medicaid Management Information System, and this is the system that's approved by CMS for us to utilize for our claims and prior authorization processing. And so when changes are made to the Nevada Medicaid program, sometimes there's system updates that are needed in order to accommodate those changes. Our billing manual and billing guidelines by provider type are procedural documents that work in concert with the Medicaid Services Manual. They're maintained by our fiscal agent, and they sort of just provide some support and instructions for Medicaid billing. The fee schedule is a listing of reimbursable services as determined by the division's respective policy teams. And our rate analysis and development unit uses the methods and standards in the state plan to determine the appropriate reimbursement rates for each service. Next, we have federal waivers. So there's provisions in Medicaid law that allow the federal government to waive certain rules that apply to Medicaid in order to allow states to provide healthcare options that are tailored to groups with particular needs and health conditions. And so these waivers must also be submitted to and approved by CMS. And the last one we have is RFP, or request for proposal. And this is part of the vendor procurement process where states solicit a vendor to perform certain activities related to the administration of their Medicaid programs. And so with that, I think I'm handing it off to Kimberly Adams for the next slide.
Good afternoon. My name is Kim Adams. I'm with the Fiscal Services Unit with Nevada Medicaid, and I will be going over all of the provider rate changes coming out of the legislative session. Before I get started on talking about the specific bills and rate changes, I did want to briefly touch on what the rate update process looks like, as many of these rate increases are going to be applied retroactively due to when we receive federal approval on the various rate changes. So just wanted to touch on that briefly. Once we have received federal approvals, we let our systems team and our fiscal agent know that we're clear to move forward on those rate increases. We're not able to implement those until we have that federal approval. Our fiscal agent then makes the system updates and conducts testing as needed to ensure the rates and the updates are working as anticipated. Once the rates have been updated in the system, then any claims billed after that date with a date of service on or after the effective date will pay at the increased rate. So for example, if we're looking at rate increases effective January 1st, 2024, and the system updates were made February 1st, 2024, any claim billed prior to February 1st for dates of service 1/1 forward would have paid at the prior rate. Those claims would then be reprocessed after the rate updates are made. So there's a different process for doing that. It doesn't happen simultaneously with the rate update. It takes place after that point. And then any claim billed after February 1st for dates of service 1/1 forward would pay at the higher rate without reprocessing. Just as a reminder, providers should be billing their usual and customary charges rather than the current reimbursement rate unless there's specific guidance for that provider type in a billing guide or the Medicaid Services Manual that indicates otherwise. This ensures that claims will be captured in that recycle, reprocess system, as our MMIS uses a less than logic. So it looks at either the lower of the maximum fee or the billed charge. So if the amount billed is less than the new rate, then typically those claims will not be picked up in a recycle. Okay, so starting out with specific rate changes, Assembly Bill 237, this bill authorized a 14.5% increase for skilled nursing facilities. This increase is in addition to the 10% rate increase approved in the DHCFP budget for a total increase of 24.5% for the skilled nursing facilities. This state plan amendment is still pending approval from CMS. We're continuing to work with CMS on providing the requested information they need to move that SPA to approval. Next up, Assembly Bill 277. This is the reimbursement portion of the new rural emergency hospital distinction. We posted public notice on December 28th, 2023 to hold that January 1st effective date and plan to take this state plan amendment to hearing in March of 2024, but it will be made retroactive back to January 1st, 2024. Next up is Senate Bill 241. This related to cost-based rates for critical access hospitals. So this includes cost-based outpatient rates for public critical access hospitals and cost-settled rates for swing bed services provided by critical access hospitals. Public notice was posted on December 22nd, 2023 to hold the January 1st effective date, and we'll also be taking that SPA to hearing in March of 2024 with a retroactive effective date of January 1st. We'll also be making adjustments to switch from cost-settled inpatient rates to cost-based inpatient rates for all critical access hospitals to streamline processes and get hospitals that funding sooner. And then in the meantime, we've been setting up meetings with the Rural Hospital Association and going over specific rates for each hospital just so they know what to expect. And then last on this slide is Senate Bill 504, the rate increases for applied behavioral analysis. This SPA was approved by CMS on November 8th, 2023. And the rate updates are in process. And once those rate updates are made, claims will be reprocessed back to July 1st, 2023. Next slide, please. Okay, also under Senate Bill 504 is the 5% rate increase for dentists. That state plan amendment was approved by CMS on November 30th. We're working through some possible discrepancies with the current reimbursement rates prior to applying the rate increases. We did an audit of the calculations that are used to set each rate and found some inconsistencies. So we're looking into those a little further before we push that rate increase through. Next up, under SB 504, our frail elderly waiver residential facilities for group rate increases. That waiver amendment was approved on December 13th, 2023, and we are just pending system changes to update the rates in MMIS. Senate Bill 504, the 5% physician rate increase. This state plan amendment is still pending with CMS. They don't have any major concerns with the content of the physician rate increase itself. We're making some other changes to that state plan page for other provider types. And so CMS has indicated that a different state plan amendment needs to be approved first prior to approving the 5% rate increase for physicians. So we're working with CMS on that other state plan amendment to move that one forward so that the rate increase for physicians can go through as well. And then last on this slide, this is the other piece of the skilled nursing facility rate increase. This was the 10% portion that was included in the DHCFP budget under SB 504. And so this one also is still pending CMS approval. Next slide, please. Okay. Also under Senate Bill 504, we have payment parity for advanced practice registered nurses and certified nurse midwives with physicians, including the pediatric enhancement and after that 5% rate increase for physicians. This state plan amendment is in the same SPA package as the physician rate increase, so it's also being held up by that other state plan amendment, but we're hoping to move those forward soon. Also under Senate Bill 504, the home health and private duty nursing rate increase of 15%. That SPA was approved by CMS on November 17th, 2023, and we're just pending those rate updates being made in the system. Under Senate Bill 511, rate increases for personal care services and personal care-like services under some of our waiver provider types. We have received a lot of questions about these SPAs in particular. The SPA portion for provider types 30 and 83 was just approved by CMS last week on January 12th. And then the waiver amendment was approved as well for the PCS-like services under provider type 48 and 58. We are prioritizing implementing these rate changes as quickly as possible because there is that wage requirement along with them. The tentative dates for the system updates are January 22nd for provider types 30 and 83 and January 29th for provider types 48 and 58. And there will be a web announcement being posted soon to communicate that as well. And if you have not yet returned the attestation forms that go along with those rate increases to attest that you will be paying your employees that $16 per hour wage, we encourage providers to do so as quickly as possible, as we do have to have that on file for the provider to be eligible for that rate increase. Next up, Senate Bill 504, also under the frail elderly waiver for assisted living facilities. That waiver amendment was approved on December 13th, and we are working to implement the system updates. And then last on this slide is Senate Bill 280, having to do with IUDs and long-acting reversible contraceptives and unbundling those costs. So public notice was posted for both general acute hospitals and critical access hospitals to hold the January 1st effective date. We're also anticipating taking those to public hearing in March with that retro effective date back to January 1st. So hospitals will be able to bill both the insertion and removal procedure code and the device for that LARC or IUD separately from the inpatient per diem rate. And then not necessarily strictly tied to SB 280, but related, we're also implementing the same allowances for federally qualified health centers and rural health centers to allow them to also bill LARC insertion and removal procedures and the device separately from their encounter rates. And I'm happy to take any questions on the rate increases at the end of the presentation. And I believe I am turning it over to Yvette Cullen for the next slide. Nope, that's Sarah Dearborn. Sorry.
No problem at all. Thank you. So I'll get us started talking about our bills related to our benefit and coverage changes. So first, Assembly Bill 137 requires the division to develop services for individuals with fetal alcohol spectrum disorder. The division has been researching a new to Nevada health home benefit authorized under Section 1945A of the Support Act, and how this can be used for individuals with fetal alcohol spectrum disorder. This will also require a state plan amendment, likely a new Medicaid service manual chapter, as well as Medicaid management information system updates. This bill has an effective date of January 1st, 2024, but with the development of this brand new model, we will require some support from a vendor, we are hoping to secure and get started on early of 2024. The next bill, Assembly Bill 138, requires the division to reimburse for behavioral health integration services. This will support expanding access to behavioral health by integrating behavioral health into primary care settings. This will require a state plan amendment, possible updates to Medicaid Service Manual Chapter 600 for physician services, and Medicaid Service Manual Chapter 400, mental health and alcohol and substance use services, as well as adding new billing codes to the Medicaid Management Information System. This bill has an effective date of July 1st, 2024, but because this is a new program, we hope to hold a public workshop to engage feedback, hopefully around April of 2024. Because this bill is not effective until later this year, it is uncertain how it may be impacted by other bills that were passed during this legislative session, and absolutely more information to come and specifics on this bill as we move forward throughout the year. Next is Senate Bill 119. This provides authority for the state to pay the non-federal share of expenses for services in the same amount as in-person or by other means for counseling or treatment relating to a mental health condition or a substance use disorder, including without limitation when such counseling or treatment is provided through audio-only interaction. This bill required edits to Medicaid Service Manual Chapter 3400 for telehealth services, as well as Medicaid Management Information System updates. This bill had an effective date of July 1st of 2023. Our approved edits were approved at our November 28th, 2023 public hearing. There are a couple remaining system updates that our fiscal agent is working to complete to ensure that all behavioral health codes can be billable with telehealth modifiers, which should be finished mid-March. But the fixes will be retroactive back to the effective date of policy, which was November 29th of 2023. Next is Senate Bill 191. This requires Medicaid to expand applied behavioral analysis services from individuals 21 and younger to 27 and younger. The division has determined to open this benefit up to all ages of Medicaid eligible individuals in need of applied behavior analysis services. This bill will also require updates to Medicaid Service Manual Chapter 3700, Applied Behavior Analysis. It will require Medicaid Management Information System updates as well. The effective date of this bill is January 1st, 2024. We anticipate, as I mentioned previously, taking this to public workshop next week, January 23rd, so please join us. And hopefully a state plan amendment as well as those MSM changes to be heard at our March 26, 2024 public hearing. And now I'll pass it to Jamie, I think is next.
Yep, it's me. Senate Bill 146 revises regulation to authorize a certified nurse midwife to perform a physical examination or obtain a medical history before or after a patient is admitted to a hospital for the purpose of giving birth. DHCFP reviewed the MCO contract and executed an amendment on December 22nd, 2023 that included the language from the bill to ensure MCO compliance, and this bill is now fully implemented. I think next is Kim.
Yeah, That one's me. The Senate Bill 439, the Communicable Disease Coverage Bill. This bill requires us to pay physicians' assistants in parity with physicians when they are diagnosing, treating, or preventing HIV or hepatitis C. This is part of the same SPA package as the physician rate increases and the APRN and certified nurse midwife parity. So these are still pending CMS approval, but being held up by a different state plan amendment right now.
I will jump into Senate Bill 504, which is part of the large budget bill. And this addresses Medicaid eligibility for pregnant women up to 200% of the federal poverty level. And I'm so sorry, let me introduce myself. My name's Yvette Cullen, and I'm the chief of the Medical Benefits Coverage Unit. We submitted a state plan amendment. It was approved December 15th of this last year, and it was effective January 1st. And I believe, Sarah, you have the next bill.
I do. Thank you so much. Also, as part of Senate Bill 504, or part of the Medicaid budget, the elimination of neurotherapy and biofeedback for treatment of a mental health diagnosis is required to be eliminated. This will require a state plan amendment as well as a Medicaid Service Manual Chapter 400, Mental Health and Alcohol and Substance Use Service Update, as well as an update to our Medicaid Management Information System to remove these codes. These services will be removed effective April 1st, 2024, and we anticipate taking these changes to our March 26, 2024 public hearing.
Senate Bill 163 is requiring Medicaid to cover treatment of additional procedure codes related to gender dysphoria and gender incongruence. We submitted a state plan, which is approved by CMS on December 1st. Our manual was updated at our October 31st public hearing, and there are system updates in progress. This was effective October 1st of 23. AB 277 is regarding rural emergency hospitals. It creates a new provider type for these rural emergency hospitals. This policy is effective January 1st. Our state plan is pending CMS right now, and our manual update was approved at our December 26th public hearing. Next bill is Senate Bill 117, and that is regarding additional provider types to supervise community health workers. The state plan amendment is pending CMS right now. Our policy update was approved for our manual at our October 31st public hearing. And I'm going to move over and let Kim discuss the rates part of this bill.
Thanks, Yvette. So similarly, the rates portion of the state plan amendment is also pending CMS approval. We're working with CMS to move that along. It's been combined with our doula rate increase, I believe.
The next bill is AB 155, biomarker testing coverage. And that requires Medicaid to include biomarker testing coverage for the diagnosis, treatment, management, and ongoing monitoring of cancer. Our manual update was approved at our November 28th public hearing, which makes this effective 11/1, and our system updates are in progress right now. Next bill is Senate Bill 221, which is revising provisions, related to Medicaid reimbursement for special clinics treating children with cancer and rare diseases. Our policy state plan amendment was approved December 5th. Our manual update approved at our October public hearing, and then I will move back over to Kim.
Thank you. So for the reimbursement portion of Senate Bill 221, we presented those pages at a public hearing on December 26th and just received our first round of questions back from CMS on that state plan amendment last week, and we'll be working on responses related to that SPA. I'm going to hand it back to Yvette.
Senate Bill 232 requires Medicaid to include coverage for postpartum care services up to 12 months. This state plan is pending CMS right now. Our manual update was approved November 28th public hearing. This was effective January 1st, and DWSS is working on their system changes, which are implemented last month. I'm sorry. And then our system changes for MMIS were effective December 18th. This coverage has been implemented. The Senate Bill 280, contraception provisions. It revises provisions making long-acting removable contraception, known as LARCs, available after birth for recipients. The policy manual update was passed at our October 31st public hearing, and system updates are in progress right now. I will turn off my camera and let Kirsten Cullum do her updates.
Thanks, Yvette. Hi, I'm Kirsten Cullum. I'm the Chief for Long-Term Services and Supports, and just here to give a couple updates. So our first bill is one of those bills, as Stacy mentioned, as a little bit later effective date, and so that is for AB 208, our new, it's going to be a new waiver, so that is structured family caregiving, and so we've started the project management on that and hiring staff, and we hope to have a public workshop and public engagement a little bit closer to April of this year. We're still working on drafting that application and working with our partners at Aging and Disability Services on that. The second bill is AB 259. So this is to add a new benefit to the ID waiver. And so as you might be familiar, we had a rate increase to the ID waiver that we is our phase 2, really, that we are working towards an April 1st effective date. So the waiver amendment to add that second phase 2 for the ID waiver rate increase is with CMS now. So once CMS approves that application, which we just submitted on January 4th, so once they approve that for that rate increase, then we'll be able to start making changes to that amendment. Essentially, we can't have multiple changes to the amendment at multiple times. So we have to wait for changes to be adopted, and then we can work on another amendment. And then for SB 4.5, we so this is actually it's not necessarily for home and community-based services per se, but it is for individuals that are in a nursing facility, and so this is related to their personal needs allowance. And so this one has taken us a little bit of time. Our estate plan, I think it's almost like 20 years old, and so we have been CMS, our federal partners, Centers for Medicare and Medicaid Services, have been gracious enough to work with us informally so that we can make sure that the updates that we need to make for this personal needs allowance is the language we use is correct. And so we just had a meeting with CMS about 2 weeks ago, and we're also working closely with our partners over at Division of Welfare and Supportive Services. And so we just submitted we hope to be our final draft language for our state plan amendment page for this SPA section. And then CMS is currently reviewing that. And so once they kind of give us the go-ahead that our draft language is good, then we will officially submit it, through our portal process. I will say, so good news is that CMS did confirm that for this section of our SPA, we can do a retroactive effective date. So so that is the great news, and any approval for this SPA language will go back to January 1st of 2024. And then once we have a better understanding of how that looks like in our system impact, then we'll work on noticing stakeholders and working closely with our partners over at Aging and Disability Services to help with disseminate that information to recipients, and as well as to our providers, our nursing facility providers. So that one is still sort of pending in the process, but hopeful that we will have that updated fairly soon. And then, so the other two bill updates we have is that rate increase. So that was the one I just mentioned for the ID waiver. That's the phase 2. Phase 1 was already actually in effect July 1st. We used the emergency authority for the Appendix K. So phase 2 is the one that we just submitted the waiver application January 4th. 4th for an April effective date. And then the waiver slot increases that we got from session, those actually that is completed and that's all done. So for the ID waiver, that we actually included that in our ID renewal that we received approval October 2nd of last year. Or apologies, that should be October 1st. That's a typo of last year. And then for the elder and physically disabled waiver, that we received that approval December 13th. And so those are our updates, and happy to answer questions at the end. And I believe Dr. Benson might be up.
Hello again, Dr. Keith Benson, State Dental Officer with some dental updates. SB 310 was expanding scope of dental auxiliaries, which would include dental hygienists and dental assistants. The portion that Medicaid is implementing is dental hygienists will now be able to prescribe preventative medications. And we're looking at system upgrades to track those hygienists and to make sure that those prescriptions are being paid at the pharmacy. Next is SB 385, which is the addition of crowns, fillings, and dentures for adults in Medicaid. And that state plan amendment has been submitted to CMS, and I believe next week we have our first call with CMS regarding that SPA. Next is AB 147, which is teledentistry and vaccines. And so that would allow dentists to do some procedures through teledentistry and administer vaccines. We're awaiting the Nevada State Dental Board to develop regulations around, for instance, what vaccines will be available for dentists to provide, and some regulations around teledentistry. So that one's on hold until those regulations have been developed. And then I also just wanted to speak about the ID dental waiver, which we've hit 1 year of service. We've reached about 26% of the participants on the ID waiver, which is 788 recipients. We've had 199 rendering providers thus far, and I am currently trying to add more dental services to that waiver program. So thank you very much, and I believe it's Dr. Duncan next.
Good afternoon. This is Sarah Dearborn. I'm going to fill in.
Sorry,
for
go
Dr.
ahead,
Duncan.
Sarah. Sorry, go ahead.
No,
I'll
you're
do mine
fine.
after.
You're fine. So for Assembly Bill 156, this requires the division to allow for services of a pharmacist to assess a patient to determine if the patient has an opioid use disorder, determine whether medication-assisted treatment is appropriate, counsel the patient, and prescribe and dispense a drug for medication-assisted treatment at a rate equal to the rate of reimbursement provided to a physician, a physician's assistant, or an advanced practice registered nurse, a state plan amendment, as well as a Medicaid Service Manual, Chapter 3800 for medication-assisted treatment, as well as Chapter 600 physician services. Updates were all presented during our November 28th, 2023 public hearing. We are currently working with CMS on proposed edits to our state plan amendment, as well as collaborating with Dr. Duncan, our pharmacy director, and the Board of Pharmacy, just to ensure that these edits proposed are all appropriate. And Jessica, I'll turn it over to you.
Hi, Dr. Duncan isn't able to attend, so I'm Jessica Benucci. I'm the Social Service Program Specialist in the Pharmacy and DME unit. Regarding SB 504, adding coverage of the wearable cardiovascular defibrillators that were approved in the last session. Currently, we've got the codes and the rates sent over to the MMIS system, and they've been updated. So currently it's going through testing, and we're hoping that everything will be good to go by the end of this month. Additionally, the MSM Chapter 1300 for the DME policy updates are coming for February 29th, 2024 public hearing. We just completed the public workshop that was conducted on January 16th, and everything looked good coming from that workshop. I think it is Michael Gordon next.
Okay, good afternoon. Thank you. My name is Michael Gordon, Director of the New Waiver and Stakeholder Unit. AB 389 is an 1115 waiver to serve certain incarcerated populations in Nevada. It is meant to help build a healthcare bridge for incarcerated individuals to be successful in the community once released. Our goal is to have the waiver submitted to CMS by January 1st, 2025. We'll be working with the waiver vendor within the next few months to get the process moving forward.
Michael, did you also want to go over the second SB 504, or would you like me to take that?
I would like you to take that. Sorry.
Okay, no problem.
Yeah.
Good afternoon, everyone. My name is Melinda Southard. I'm a Deputy Administrator here at the Division for Community Supports and Engagement. And we just wanted to provide a quick update that we did receive some funding for waiver support, specifically for or vendor support, I should say, specifically for our federal waivers and developing all those applications and all the necessary administrative work that goes with that. So we are looking to go to the board examiners for those vendors in February and hope to start work very soon after that. So yeah, we'll go ahead and move to the next slide. So for this slide, I intended to give you a list of some of our upcoming public hearings, as well as links to where you can go for more information on all of our public meetings, including the public workshops you just heard mentioned from our team today. I also wanted to highlight the new Community and Provider Engagement Unit email inbox here. This new inbox is meant for our provider and community partners and stakeholders to use when they just aren't sure who might be best able to solve their problem or answer their question best. The team on the other side of this inbox will help route your inquiry to the appropriate person in the division, and we'll get back to you promptly with an answer. So please feel free to reach out anytime. On this next slide, we wanted the opportunity to highlight for you all the different committees and groups under the management of the division. So I'll first go ahead and hand it off to Monica to get us started with the Medical Care Advisory Committee.
Thank you. Good afternoon, everybody. This is Monica Schiffer with the Community and Provider Engagement Unit. The Medical Care Advisory Committee was established through Nevada Revised Statute 422.151 through 422.155 and is also supported by 42 CFR 431.12. The function of this committee is to participate in policy development and program administration, including furthering the participation of beneficiary members in agency programs and advising the administrator regarding the provision of services for the health and medical care of Medicaid recipients. This committee also reports annually to the DHCFP administrator related to recommendations to improve Medicaid or increase access to health insurance for vulnerable individuals. The next committee is the Medicaid Reinvestment Advisory Committee, and this committee was established per Nevada Revised Statutes 422.175 through 422.205. This particular committee only applies for counties with a population of 700,000 or more. So currently it only impacts Clark County. The function of this committee is to make recommendations concerning the reinvestments of funds by our managed care organizations for such things as innovative partnerships with community development organizations and providers of housing services, and also supporting the initiatives of local governments in the county to address homelessness, housing issues, and social determinants of health. Additionally, this committee prepares an annual report regarding the activities of the committee, and that is submitted to the Legislative Council Bureau, to the on healthcare, or it goes to the legislature during regular session. I'd also like to point out, if anyone is interested in serving on any of our advisory committees, you can find the application located on our website, which is dhcfp.nv.gov, under the tab labeled Boards and Committees. Thank you.
Thanks, Monica. To continue on here, the division also manages the Advisory Committee on Medicaid Innovation, which is intended to make recommendations to our department director about opportunities to improve access to Medicaid or other forms of coverage. This committee has been on hiatus for a little while. However, now with the recent reorganization at the division and our new community and provider engagement stepping up to manage these committees, the division is looking forward to revitalizing this committee in the coming months. Next, we have our newest committee, the Electronic Health Information Advisory Group, which came about as a result of the passage of Assembly Bill 7. The intent of this group is to advise our director on adoption of regulations prescribing standards related to electronic health records, health-related information, and health information exchanges. The division is still accepting applications for the membership as described in the bill. You are more than welcome to navigate to the website shown here to the right for more information and a link to apply if interested. The division expects to kick off this advisory group next month. Now I'll go ahead and hand it over to Jessica to review our last two committees here.
Great, thank you, Melinda. So we have the Drug Utilization Review Board, the DUR Board, and this establishes prior authorization and quantity limits to certain drugs and drug classes based on utilization data, experience, and testimony presented at those meetings. The DUR Board meetings are quarterly and they are open to the public. We also have the Silver State Scripts Board, SSSB, which was established to identify prescription drugs to be included on the preferred drug list, the PDL, a non-restricted formulary. The SSSB meetings are quarterly and they are also open to the public. Thank you.
All right, I think Melinda, it's me again, right? So thank you. So for now, as we turn to the next session, over the next year, we are going to be building our budgets. And one of the things we wanted to do today is do a little recap on Medicaid financing, really high level about what it is and how it works, and then talk a little bit about the budget planning process. As you may know, it takes us about a year. And so we are already starting that now with our director's office, as well as working with GFO and other partners as we build our budget for legislative session in 2025. Real quick, when we think about Medicaid financing, it's always important to remember but one of the reasons it's kind of a good program, right? We can draw down federal funding. So it's a jointly financed program by state and federal funds. Each state has a little bit of a different federal match that they can draw down, but overall, every state receives at least 50% or more. Ours is around 60%. We receive 60% federal share and we pay the 40% of the cost of the program. The federal government pays for, like I said, the share of our costs of our program when it comes to allowable services. So this means that they have to be approved in our state plan or we have some kind of waiver authority to cover them. There are mandatory services, but when there are optional services, we definitely need to make sure that we have these authorities to cover them. We also can draw down federal funding to do administrative costs as well as technology costs, and we do get a little bit of a different federal share there as well, so we can kind of maximize more money. State Medicaid programs must be able to cover the state share of their program, either with state general fund or other state dollars, or local funds from like counties, or also we can do public funded universities can also pick up some cost, but everything we fund, we have to have state share accounted for and in our budget, or we cannot receive federal matching funds. States request federal funds quarterly, and we report on those on the amount that we're owed quarterly. Our state program spending is audited by the federal government. I just want to stress here that we see more of this now than we have always in the past. So it's really important for us that we make sure that we are following our requirements outlined around payment. Next slide, please. All right, so as we're moving forward for the 2025 session, one thing to think about is that, and we get asked a lot, like, can you increase our provider rates? Can you add this service? Can you cover this? And, if we could have it our way, I think it would be such an easier conversation. But when we think about when we actually are going to increase provider rates, we increase them by the entire provider type. We can't treat one provider differently that's part of a provider type. For example, we can't pick one physician out of the state and give them a better rate than other physicians, right? We have to increase all provider rates at the same time for a certain type of provider. Same, add services, and then to do that, we have to really request additional state funding from the legislature. We are really funded right now according to what is approved in state law and our state plan and policy, and that's in our what we call our base spending. In Nevada, to increase state spending in our base, we really need to ask for funding from the legislature, but this occurs every 2 years in Nevada. So we just had one, right, last session, and now we're going to have another session in 2025. And right now, like I mentioned, we are preparing for and we put our proposals in what's called the governor's budget proposal. Sorry, some reason when I speak on these things, my throat closes. So like other agencies, we do not know right now how much or if we're going to get any funding to spend in addition to our base. So I think it's important to remember that these are decisions that will be part of a larger conversation about how the state's budget is spent on healthcare, education, transportation, all the other things that have to be funded. But right now, we're still putting together what we'd like to have, or at least think is important for the governor to consider. As you probably know, information pertaining to the development of the budget is confidential until the budget package is released. So we can't really tell you if it's in or out, but we are here and looking for feedback and ideas and want to make sure we're able to have these conversations. And I just want to stress that if you don't get a chance to speak today or you come up with an idea later, please send it in to our community stakeholder email address, and we will collect it from there and take it into consideration. Next slide, please. Okay, so right now, as we're building the budget, these are sort of the big key areas of focus for us. And that really, I wouldn't consider, there's so many things in Medicaid, there's so many important issues. So I just want to stress that if you don't see your issue or the thing that you wanted to bring up today, or you feel is really important, it doesn't mean it's not important and we don't care about it and we're not focused on it or we won't look at it or consider it. It's just when we think of where the governor's administration is going and kind of where Nevada's biggest gaps are, these are the things that come to mind. And we always think about them, the fact that we have limited resources, right? So we really got to think about how best to spend those and to maximize federal dollars. So the key areas of focus for us right now, the big one is better government, right? So making our lives and providers' lives and our recipient lives easier on Medicaid, right? So making that process easier, modernizing our program, making it more efficient, but also compliance is key here too, and making sure that our division is able to keep up with all the federal regulations. And so we don't ever find ourselves in a position where we owe the federal government money or there's some kind of take back because we are not in compliance. Improving behavioral health care. This aligns with a lot of the work we did last session with the provider tax, where we got a percentage of that tax to help pay for children's behavioral health care. But as you guys know, there's still work to do. And those fundings too, we will max them out with the DOJ settlement agreement. And then there's still other work to do, especially around adults, because children, as you all know, grow up and still have needs. And we still need to make sure that our adult population is being served. So behavioral health is a big one, and it's a statewide crisis and issue. Improving maternal and child health. We have some of the worst outcomes for moms and babies in the state. In Nevada, 1 out of every 2 births is paid for by Medicaid. So we have a real opportunity to improve that just based on the fact that we are often the biggest payer for children when it comes to births. And moms, a lot of pregnant women get their care from Medicaid. Better access to care for rural communities. This one is, as you all know, is a big priority for the governor. It's a big priority for us as well as we move to statewide managed care. And then also modernizing how we pay for healthcare. So as we think about our budget, if we want to continue to grow Medicaid, we have to often remember that revenue for the state is very limited. There's no new revenue options on the table. And so as our budget grows, it squeezes all the other areas that the state must pay for: education, transportation, like I mentioned earlier. So how do we modernize how we pay for healthcare so we know we're getting the best deal for the taxpayer dollar? And so that's really looking at value-based care models, reforming some of our payment structures that we know are not serving us well, and that really are trying to get at better quality and rewarding providers that are getting us that better quality, or trying to figure out how do we help providers get that funding to do that work. And last but not least, it's always important to go upstream and improve access to care and healthcare through prevention and primary care. I think you all are aware that we have a primary care huge shortage gap in the state for primary care providers. And it's something we're really focused on, especially in our managed care program, and trying to drive more spending in that direction. I think that's it. Next slide. All right, so we were going to open it up for public comment on budget priorities. Melinda, did you want to kind of walk through that process?
Sure. Thank you, Stacy. So if you would like to raise public comment, please use the raise hand feature in the Teams platform, or if you are calling in on the phone, if you could press *5 to raise your hand, and I will go ahead and call on you in the order that those hands are raised. So first we have Blaine Osborne. Please go ahead.
Hi, thank you, Melinda. Blaine Osborne here, Nevada Rural Hospital Partners. First, I want to thank you, Stacy and Melinda, your entire team at Nevada Medicaid. Thank you for putting this together and sharing it with us, as well as for prioritizing particularly rural care and improved access. Respectfully, one of the things that I would ask the division to consider for the next budget, the next legislative session, is for the unbundling of surgical implants, covering the cost of the devices outside of those bundled rates. What we've found is that often these bundled rates no longer sufficiently cover the cost of the device. And so would really, again, respectfully request for that to be considered the next legislative session. Really appreciate your time, and thank you again for doing this.
Thank you, Blaine. Next, we have Gina Hernandez. Please go ahead.
Hello, my name is Stuart Wickers, Dr. Stuart Wickers. Last name's Weichers, first name Stuart. I am an owner of Sun Valley Surgery Center. And just a quick summary. In Nevada, about 80 to 90% of pediatric and special needs dental cases that require general anesthesia are done currently at only one ambulatory surgery center. In 2017, many ASCs did these cases, but at the time, rates were cut to align with Medicare rates, even though Medicare did not have a billing code with a rate for these procedures at that time. Predictably, every ASC in Nevada, except one or two, closed their doors to these procedures. Wait times to get into ASCs skyrocketed, and 95% of these children that required general anesthesia for dental care are on Medicaid and have rampant dental decay. The unintentional consequence was many children going to the emergency room for non-definitive and extensive treatment. Today, there is even more urgent crisis threatening this population and their access to definitive dental care. Increasing supply costs, labor, and poor Medicaid and reimbursement for anesthesia providers is making it almost impossible to continue providing care for this population. Fortunately, the state dental officer, the Oral Health Advisory Board, and the state Medicaid administrator have listened and recognized the urgency of this access to care crisis and have given some temporary reprieve. To address the access to care issue on a national level, Medicare created a new code, G0330, and recommended a new rate, which is roughly double what is paid in the state of Nevada for Medicaid. This coda rate has not been adopted in Nevada yet. And our goal today is to implore the state to consider aligning their rates with Medicare for these procedures as the new budget is proposed for 2025. This will enable us to continue providing care for the most vulnerable in our population, our children and special needs adults. Thank you.
Thank you, Stuart, and I apologize for getting your name wrong there. Next, we have Leah Case.
Good afternoon, all. Thank you. Leah Case, Bells and Case Government Affairs, here today on behalf of the Nevada Speech Language Hearing Association. Shauna Ross submitted a letter 2 days ago, I want to say yesterday, might have been yesterday, detailing some of the requests from the Speech Language Hearing Association. Relatively minor compared to what we just heard, and ditto Blaine's comments on thank you for putting this on, and the transparency in the process has been fantastic. For the Nevada Speech Language Hearing Association, provider type 34, there are 2 CPT codes 3 CPT codes that are reimbursed at $0. That's 92612, 92511, and 31579. Different types of endoscopies for evaluating swallowing and speech. Those are all reimbursed at $0 for speech language pathologists and the specialists who do that. Physicians can be reimbursed for those codes, but there are no physicians that perform those procedures in Nevada that we've been able to find. So looking at getting a reimbursement rate for those diagnostic endoscopic evaluations. And secondly, provider type 34 practices in a school setting, and there is a misalignment between what speech language pathologists are paid when they see a child in private practice and what they're paid in a school-based setting. So they would like to see some parity between those two rates. It's the same skill being used, it's just a different setting. And that is the Speech Hearing Association of Nevada. And thank you very much.
Thank you, Leah. Appreciate that. Next, we have Jeffrey Bartow.
Yeah, good afternoon. This is Jeff Bartow with Homestyle Direct. I'd like to also reiterate Blaine's comments and appreciation for the transparency today. Thank you so much for the opportunity to make comments. So Homestyle Direct is a home delivered meal company that services the state of Nevada and waiver participants in the state of Nevada. Mostly under the disability waiver, but also under the frail and elderly. We have recently, over the last 2 or 3 years, kind of encountered an economic challenge in providing the state continued services. And what I mean by that is the meal rate that we receive from the state today is around $5. As we've kind of went through the pandemic, we've seen increases in both food and fuel costs. We have seen most other states, almost all, on their Medicaid program or waiver, home and community-based services type offerings, increase rates as a result of this inflationary pressure on home delivered meal companies. We are seeing over the states of Oklahoma, Idaho, Wyoming, Utah, Montana, Kansas, North Dakota, Minnesota, Iowa, Nebraska, Texas, and Colorado, all of which have very similar programming and that we serve, average a meal rate around $7.50. So about $2.50 higher than where we're at in the state of Nevada. And we service about 37 to 38% of all recipients getting home delivered meals in the state. That's about 569 members. And last year we serviced them with 168,000 meals in total. The total consideration here, I think, is about 1.1 to 1.2 million in additional total dollars. That's the total nugget, federal and state. And so we believe that there should be some consideration there made from a rate perspective, in addition to looking at expanding us across all three waiver offerings: frail and elderly, physically disabled, and the IDD. And the reason for that being, obviously, home delivered meals allow people to age in place, stay at home, remain in the lowest cost of care setting, as opposed to being institutionalized, which is our biggest value proposition. Thanks for hearing me out. We hope you guys consider that in the upcoming budget, and I appreciate the time today.
Great. Thank you, Jeff. Next, we have Jay Colbert-Klossel.
Hello, thank you so much. My name is Jay Colbert-Klossel, Program Director for the Community Health Worker Association in Nevada. I want to applaud you all for waiting on that state plan amendment. We know that we're kind of in a holding pattern, but we look forward to promoting CHW reimbursement in those additional settings and with those additional supervisors once that state plan amendment is approved. I know we were hoping for this month, but we'll get there. The public comment that we wanted to share today is that we want to applaud your work on moving towards managed care for the entire state, and then just express what we believe the needs are to achieve that. What we've seen from federal requirements is that they're requiring over 70 data points about the social determinants of health and a lot of those disparities for each client. And a lot of the hospitals aren't really in a position to collect that level of data. So we're hoping that the plan that comes out, or the implementation of the plan that comes out, really gears up for that and helps foster those partners between or partnerships between the hospitals and the community organizations. Especially in a lot of the rural areas, the same facility is both the plant nursery, the dental outreach, the school-based social workers, everything out of one small building, if you look at my home office in Dayton. And we just have to be communicating on another level to get all of those data points in those really hard to reach areas out. And we do believe community health workers will help with that, but please allow room so that they can work directly for the community organizations. Thank you so much for your time today.
Great, thank you, Jay. Next, we have Amy. I'm not going to try to pronounce your last name. I apologize. Please go ahead, Amy.
No worries. Amy Sjogren with Black and Wadhams on behalf of Novo Nordisk today. I wanted to thank DHCFP for the continued discussions around anti-obesity medication and the future access to it for those who are on Nevada Medicaid. Unfortunately, the current Medicaid Services Manual does not reimburse for pharmaceutical agents used for weight loss. So we believe this language to be outdated, and until these provisions are removed, policy discussions simply can't take place as to whether coverage of FDA-approved anti-obesity medication by Medicaid is appropriate at all. So we really look forward to continued conversations and discussions around this important topic, and I thank you for the time.
Great, thank you, Amy. Again, if you have any public comment that you would like to share, please use the raise hand feature in the Teams platform, or if you are calling in, you can press *5 to raise your hand. Okay, I'm not seeing any further public comments. I did want to note we do have a survey available. If you would like to provide us some feedback on how we did today, we would really look forward to receiving that and learning how we can do better and engage better with all of our stakeholders and community providers. And I'd like to pass it to Stacy if you have any closing comments.
No, other than thank you all for joining us. Really appreciate it. And if you were trying to chime in and couldn't get through for whatever reason, you can, like I mentioned, email your comments to us, and we will definitely take them into consideration as we start working on our budget. So thank you all, and I hope you all have a nice day. Thanks.